the pancreas, which also could be an opportunity. And if I look at now to the computer and also to the stage, Enrique has just arrived, who is, I think, an absolutely professional in EUS and the EUS-guided tissue acquisition in solid tumors.
Yeah, but I'm very much against that in this population. Because imagine you are 40 years of age, 45 years of age, and you have 30 years of surveillance, and in between you have 3 or 4 times the doctor is kind of a little bit worried about a lesion and starts puncturing. Every time you have a 2 to 3 kind of % risk of pancreatitis, depending on where the lesion is, because if you have traversed a large portion of normal pancreas, the risk is higher. If you add that up in the whole population that you screen, you do harm.
Of course, not all the population, but in a selected population.
But I know from discussions that there have been patients or people under surveillance who had very severe pancreatitis attacks with necrotizing pancreatitis, and you can do harm. The problem is, in particular in the FPCs, there's no evidence that we're doing anything good. Stop doing it for now. First, let's prove that we are doing something good in the high-risk population, and then start work our way back with that test to test it in the lower-risk population.
Absolutely agree.
I think what we need is a biomarker from blood, which still have nothing.
Sure, and that's of course why everybody's collecting everything.
Yeah, I mean that's where the field has to go, and rather than
and probably
poking the tissues is not it.
No, and that's a sad story. Probably a lot of these high-risk individuals have to die to give us sufficient data to work our way back to an optimal biomarker. That's the sad conclusion. Yeah.
So thank you very much indeed, Marco. Thank you. That was fantastic.
Yes, can you hear me?
Yes, we can hear you very well. So thank you very much for your very valuable time that we spent with us. I think as you could hear in the last couple of minutes, the discussions are very lively and challenging, and I'm more than happy to welcome you. And actually, like Marco, I think, who is dealing with pancreatology and also pancreas solid tumors, EUS, I think don't need too much introduction concerning Enrique Domínguez-Munoz, who is also one of the among the biggest and high-profile leaders in pancreatology, and actually concerning EUS solid tumors. I think we can learn a lot from him, and the Hungarian Pancreatic Study Group is very willing to learn from you, Enrique. So, and I am really looking forward to your talk. So the stage is yours.
So thank you very much, Peter. Thank you very much for your kind invitation. I'm very happy to be with you. Unfortunately, not in person. And I'm sorry very much for that. I will be willing to be there with you, obviously, but it was absolutely impossible. So thank you for inviting me to this special occasion, your 10th anniversary. This is really great, and I should congratulate you for all your achievements over these 10 years. And to talk, as you said before, about advanced EUS-guided imaging and tissue acquisition for the differential diagnosis of solid pancreatic tumors. The reason to talk about it is that we have contributed quite strongly to this field over the last couple of years. I hope that you are watching my slide. Are you?
Yes.
Yeah. You can see your slide.
Yes.
Okay, that's good.
But we cannot see your slide. No, it's not.
Can you?
Yes.
Okay, perfect. Well, usually the definite diagnosis of resectable solid pancreatic tumors is done after surgery. This is the usual way we do. So, and the reason for that is that there is a risk of needle tract seeding of malignant cells after percutaneous biopsy, and because we should be aware that solid pancreatic tumors other than pancreatic adenocarcinoma are quite rare. But things have changed over the last years. First of all, the development of neoadjuvant therapy protocols require a previous histological confirmation of the tumor we are dealing with. Secondly, the development of the last 20 years of EUS and EUS-guided tissue acquisition techniques have changed completely this scenario because we have an easy access to the pancreas. And we know today, and you are very well aware of that, that not every pancreatic solid tumor is a pancreatic cancer. So I don't know why, okay. Well, here you see the diagnostic workup recommended by the National Comprehensive Cancer Network, published last year. And you see that if you have the clinical suspicion of pancreatic cancer, the imaging test to do is a pancreatic CT scan. And if you see the slide, endoscopic ultrasound is just reserved for patients in which you have a resectable tumor or borderline tumor in which a neoadjuvant therapy is considered. However, if you take into account the accuracy of endoscopic ultrasound compared to CT scan in the detection of pancreatic solid tumors, you can see that all these studies have shown a higher sensitivity of endoscopic ultrasound compared to CT scan in detecting solid pancreatic tumors. So we could change the protocol and said, well, why not to do EUS from the very beginning when you suspect a solid pancreatic lesion or pancreatic cancer, because endoscopic ultrasound is more accurate than CT scan. And this is especially true for small tumors, for those tumors which are resectable. And actually, here you can see the studies comparing endoscopic ultrasound and CT scan, the sensitivity to detect tumors smaller than 2 or 3 centimeters, or even smaller than 1.5 centimeters. In all these studies, you can see that the accuracy or the sensitivity of endoscopic ultrasound is very high, normally higher than 90%, whereas the sensitivity of CT scan to detect these small resectable lesions is quite low. And the third point I wanted to tell you is that not everything is adenocarcinoma. Not any time that you see a solid tumor in the pancreas is a pancreatic cancer. Look, this is a series, a prospective series of consecutive patients with a solid pancreatic tumor in our hospital with histologically confirmed final diagnosis. Close to 1,000, the size was, the mean size was 3.5 centimeters. And you can see that about 74% of the tumors are pancreatic cancer. 26% of them are something different, and most of them requiring a different therapeutical approach. So not everything is a pancreatic cancer. And not only that, this is especially true for, again, small tumors. And this is a multi-center European study, including almost 400 small tumors, mean size 11 millimeters, highest, the biggest size 15 millimeters. And you can see that about half of them are benign, and only 37% are pancreatic cancer. So when we talk about resectable small tumors, we need to know what we are dealing with, because only part of them are pancreatic cancer. Here is why endoscopic ultrasound may play a very important role. Endoscopic ultrasound allows us to get tissue, to make a biopsy for histological diagnosis. We can evaluate the stiffness of the tissue or of the lesion. And you know that this is related to the histological type of the lesion. And we can also evaluate the vascularization of the lesion. Everything can be done at the same time during the same session with endoscopic ultrasound. I don't want to talk too much about EUS-guided tissue acquisition techniques, because tomorrow you have, according to your program, a specific talk about it. But as you know, this is the elective route for no metastatic disease, quite accurate, high accurate, and we can today not just to obtain cells for cytology, but core tissue samples for histological evaluation and even for molecular analysis. And you know, this is mainly indicated if you consider to perform neoadjuvant therapy in your patients. Look, talking about FNA, that means cytology, the sensitivity of EUS-guided FNA to diagnose pancreatic cancer is very high. is higher than 90%, if 91% in 2 different meta-analyses. But you will agree with me that there is a risk of false negative results by doing FNA. Today, we are prone to do FNB to get histology, to get a tissue core for histological evaluation. There are different needles. I don't want to come into details here, probably with different accuracy or different efficacy, but the mean diagnostic yield with any of the needles is about 85 to 95% for the final histological diagnosis of the pancreatic lesion. Look, there is a meta-analysis published a few years ago, putting together all the studies that have compared FNA versus FNB, cytology versus histology for the diagnosis of solid pancreatic lesions. And you can see that FNB is significantly better than FNA. And this is especially true if you do not suspect pancreatic cancer, if you have a lesion that can be something different from pancreatic cancer, or if you don't have rapid on-site evaluation in your room, if their pathologist is not with you in your room to tell you whether this is an adenocarcinoma or not. Here, just to show you some examples of FNB from our center. You see here pancreatic adenocarcinoma. This is a very interesting patient with a tissue of chronic pancreatitis. It was a patient with a chronic calcifying pancreatitis with some foci of pancreatic cancer. Here down, you can see the acinar cell pancreatic cancer or a GIST tumor. That was a patient with a large tumor infiltrating the stomach and the pancreas, and we didn't know whether it was a pancreatic or a gastric tumor. Finally, it was a GIST tumor. Just to show you some examples. So I try to tell you that FNB, EUS-guided FNB is highly accurate, but you will agree with me that the accuracy is not 100%. So there is a risk of false negative results. And it is a quite safe technique, but the complication rate is quite low, but it is not 0%. So my question is now, do we always need a biopsy? And here's where we can start to talk about advanced imaging. Basically, we are talking about EUS elastography and contrast enhancement, contrast enhanced harmonic endoscopic ultrasound. You know elastography. Elastography is a way to evaluate the stiffness of a tissue, of a lesion, and the stiffness is related to the histological type of this tissue. So you can evaluate it quantitatively or qualitatively, quantitatively by a stain ratio, histogram, and more recently, share-wave elastography. And at the end, you get a map of colors where blue is hard tissue, frequently malignant. Red is the softest you can see, and green is in between. Look, we defined a couple of years, well, it was already 12 or 13 years ago. Also, Mark Giovannini did the same. Basically, 4 patterns of elastography in pancreatic lesions. The homogeneous green pattern is the typical of the healthy pancreas. A pattern which is green predominant but heterogeneous is suggesting a benign inflammatory lesion. Heterogeneous pattern but blue predominant usually is malignant. This is the pattern that we see in patients with pancreatic cancer. And homogeneous blue pattern is quite typical of malignant G3 neuroendocrine tumors. Look, just to tell you some examples of elastography to make you understand much better what elastography can give us, can provide us. Look, this is a small tumor, which is about 1.5 centimeters, and from an elastographic point of view, is green. This is a neuroendocrine G1, a benign neuroendocrine tumor. Here in the middle, you can see a very small lesion, which is 1 centimeter in size, but from an elastographic point of view, is homogeneous blue. And this is a malignant G3 neuroendocrine tumor. And on your right, you see a patient with chronic pancreatitis, with chronic calcifying pancreatitis. The reason I want to show you this case is because calcifications are seen blue in elastography because calcifications are hard. And that's important because you should remove calcification from your elastographic evaluation. And you can see here that there is an area which is blue without calcification. We put the needle there to make a biopsy, to take a biopsy. And that was the case I showed you before with the foci of pancreatic adenocarcinoma. This is to tell you that elastography can guide you to put the needle where it's really interesting. Some studies from our group, Julio Iglesias Garcia is the man in my team doing all these studies, just to tell you that wherever you use the strain ratio higher than 10 or the strain histogram lower, below 50 is associated with malignancy. That means malignancy with an overall accuracy very high of about 98%. There are many other studies published later on with elastography, all of them showing a very high sensitivity for pancreatic adenocarcinoma is 93%, but the specificity is quite limited. This is not our experience, this is what has been published, and of course, it depends what kind of tumors are included in the control group. Look, the second technique is contrast-enhanced harmonic endoscopic ultrasound, and that allows you to evaluate the microcirculation of the tumor. You can outline much better the lesion, and of course, you can assess the efficacy of any therapy that you apply to this tumor. On the left, you see a solid lesion, which is hypovascular, typical for pancreatic ductal adenocarcinoma. In the middle, you see, again, a solid lesion, which is hypervascular. This is a neuroendocrine tumor. And on your right, again, a solid lesion, which is isobascular. And this is typical of inflammatory lesion. Again, meta-analysis evaluating the accuracy of contrast-enhanced harmonic endoscopic ultrasound for the diagnosis of pancreatic cancer. Very high sensitivity, 93%, quite high specificity, 80%. And today, we can even quantify the intensity of enhancement and the time behavior of the enhancement of the lesion to further increase the accuracy of this technique for the diagnosis of different types of solid pancreatic lesions. Well, and the final question, and I'm coming to the end, why not to combine both techniques, elastography and contrast enhancement? And there are few studies on that. The first study is from our group again, and you see that in the differential diagnosis between benign versus malignant or pancreatic cancer versus inflammatory mass in the context of chronic pancreatitis, the accuracy of combining both elastography and contrast enhancement is very high. It's about 93%, exactly the same as was reported later on in this second study. The accuracy for the diagnosis of pancreatic cancer or differential diagnosis of solid pancreatic lesions to detect malignancy is very high when you combine elastography together with contrast enhancement. And this is my final slide. This is the protocol that we are applying in our clinical routine when we face with a solid pancreatic tumor during endoscopic ultrasound. We do EUS elastography, contrast enhancement routinely, and let me tell you what we do individually according to their result. If the elastography shows you a blue pattern, we suspect that this is a malignant tumor. If this is hypovascular, this is a pancreatic cancer with a very high probability. If the tumor is resectable, we do nothing. If the tumor is borderline, or if we consider neoadjuvant therapy, then yes, then we put a needle for FNA because cytology is highly accurate in this setting. If the tumor is blue but hypervascular, this is a neuroendocrine tumor, a malignant G3 neuroendocrine tumor, or a hypervascular metastasis. In that case, we need to put again a needle, and FMB, we need tissue, and we use routinely, in that case, a 22-gauge needle. If the lesion is blue, hard, but isobascular, look, this is something that we see very often in patients with autoimmune pancreatitis. And in that case, again, we need the histological diagnosis, and we use an FMB with 19 gauge needle. Let me go to the right. You see the tumor which is green. If you see a green tumor, this is benign, per definition. If the green pattern is isobascular, this is what we see in inflammatory mass in the context of chronic pancreatitis. We don't need to do any biopsy because the diagnosis is there. If hypervascular, this is a benign neuroendocrine tumor for sure. You don't need to put the needle there. And if the lesion, green lesion, is hypovascular, this is something that we don't see so often, and we don't know what can be. And therefore, you need to do a biopsy, again, FMB with a 22 gauge needle. You see, by doing elastography, contrast enhancement, you can decide what is the better or the best diagnostic workup for that specific solid pancreatic lesion. So thank you very much. Let me tell you that next week we have the European meeting of endoscopic ultrasound in Santiago. That will be, again, a hybrid meeting. You have the website there. The registration for the online meeting is absolutely free. It will be a pleasure to have you there, even online. But if you can come to Santiago, my pleasure to welcome you. Thank you very much for your attention.
As usual, we definitely will be online at your conference. We would like to learn a lot. My question is about the second last slide. You have shown this kind of protocol. I mean, plenty of times we can see, as I mentioned also in Marco, that after acute pancreatitis or even chronic pancreatitis, it's very close, like very early tumor lesions. So when you see the green and you think that this is absolutely benignant, do you have any follow-up studies about for that how many of them, maybe in the following years, but you haven't taken a sample, turn out that there is a malignant lesion was there, which was at that stage not detectable by EUS, but maybe if you puncture, you might detect histologically?
Well, of course, we are following all the patients with chronic pancreatitis in our center. We have more than 1,000 patients in follow-up. And in our protocol, we do endoscopic ultrasound every 2 years in patients with chronic pancreatitis, with no other increased risk for pancreatic cancer like hereditary pancreatitis. And I tell you, we don't use elastography if there is not a mass. Obviously, this is one of the points. You need to see something to evaluate elastographically. If there is no mass, makes no sense, except that you use elastography for the diagnosis to confirm the diagnosis of chronic pancreatitis or to quantify the degree of fibrosis in the context of chronic pancreatitis. We have also some papers on that. But talking about your question, you need to see something. You need to see a nodule, to see even a small lesion. And I tell you, we have some cases with lesions of even 5 millimeters that you can see by endoscopic ultrasound. And if malignant, the elastographically is blue, even such as small lesions. And then it makes sense to make a biopsy if you have any doubt of that. Of course, we are talking about probabilities, but if a lesion is green from an elastographical point of view, heterogeneous, of course, but predominantly green, is with a very, very high probability a benign lesion, and you can sleep well at night because it is unlikely that you miss a malignant lesion.
Okay, thank you very much. Questions? Anybody from the audience? If not, thank you very much, Enrique. It was a pleasure being with you.